I'm Katie Doyle-Myers, and I'm the Executive Director of the Desmoid Tumor Research Foundation. I'm so pleased to be with you this evening for our webinar about the classification of desmoid tumors. We're really excited for this conversation. Thank you to SpringWorks Therapeutics for sponsoring this educational webinar. As many of you know, over the past few months, our community has come together in a really powerful way through our Spread the Word campaign. And I want to start by thanking everyone who helped our message reach farther than ever before. Desmoid tumors, as we all know, are often misunderstood. They're not benign, they're not malignant, and while they can be multifocal, they don't spread, but they can have serious life-altering effects. Getting the language right matters because it shapes how patients are seen, diagnosed, and supported. And that's exactly what this campaign is about: sharing accurate information, elevating patient voices, and making sure the desmoid community is represented clearly and accurately. And that's why we are here this evening. Our objective for this webinar is to describe from various clinical perspectives the World Health Organization's classification of desmoid tumors as intermediate, locally aggressive tumors, and to discuss why this distinction matters for diagnosis, treatment decision-making, and patient well-being. We are so grateful for all of the questions that we received from the desmoid community for this webinar. Please know that we have reviewed each and every question and will do our very best to address as many as possible today. Unfortunately, we will not be able to address every specific case. If you do not have your questions answered today, you are welcome to reach out to us at info@dtrf.org, and we will respond with appropriate resources. At this time, I am so pleased to introduce our three guests to you. Our first panelist is Dr. Mrinal Gounder. Dr. Gounder is the Scientific Director of DTRF and a member of our medical and scientific advisory boards. He is a medical oncologist at Memorial Sloan Kettering Cancer Center in New York, specializing in sarcomas and in developing new drugs in cancer. Dr. Gounder is an internationally recognized leader in desmoid tumors, has led numerous clinical trials in desmoids. Pardon me one moment. Okay. Let me come back to my script here. Has led numerous clinical trials in desmoids and led the phase 3 international studies of sorafenib and nirogacestat for desmoid tumors. In collaboration with DTRF, Memorial Sloan Kettering, IQVIA, he has developed the Goddess Patient-Reported Outcomes Tool, the first of its kind to evaluate the experience of patients with desmoid tumors. Welcome, Mrinal. We're so glad you're here.
Thank you.
Our next guest is Ashley Williams. Ashley is a licensed clinical social worker based in South Florida. She is also a certified clinical trauma professional level 2 and co-founder of the Desmoid Project. In 2015, Ashley was diagnosed with a desmoid tumor in her left leg and has since undergone 6 rounds of treatment. That experience deeply shaped both her life and her professional focus. Ashley specializes in supporting individuals navigating cancer, chronic illness, and rare disease, with a particular focus on the psychological impact of diagnosis and medical trauma. She practices from a holistic mind-body perspective and understands firsthand how illness can affect identity, relationships, and healing. Ashley provides therapy for desmoid patients, facilitates support groups through the Desmoid Project, and is currently pursuing her doctorate, where her research centers on the mental health effects of desmoid tumors. We are so glad that you are here with us this evening, Ashley. And finally, we are pleased to welcome Dr. Narsi Agaram. Narsi is a pathologist at Memorial Sloan Kettering Cancer Center. He is board certified in anatomic and clinical pathology and in cytopathology. His area of expertise is the surgical pathology of soft tissue and bone tumors. As part of the multidisciplinary teams involved in the management of these tumors, Narsi works closely with colleagues from surgical oncology, orthopedic oncology, adult and pediatric medical oncology, radiology, and radiation therapy. His role as a pathologist mainly involves establishing accurate diagnoses and, as a result, guiding treatment decisions. Working in a large cancer center also gives him an opportunity to be at the forefront of incorporating the latest molecular testing in the workup of complicated tumors such as desmoids. Welcome, Narcy. Thank you all so much for being here with us today. I'm so excited to hear from you. Really briefly, I just want to welcome everybody once again. We are so grateful to have you here for our Spread the Word educational webinar. Thanks to SpringWorks Therapeutics to sponsor this educational experience. And here's how our time together will go. For those of you that have popped on in the last couple of minutes, I want to thank everyone once again for submitting your questions to us for this webinar on desmoid tumor classification. We have received, my notes say over 50 questions, but I think we're up to 60 as of today, which is just amazing. We have reviewed each question and we'll do our best to answer as many as possible through this hour. If you do have questions beyond what we were able to cover today, please reach out directly to the foundation at info@dtrf.org, and we will do our best to direct you to appropriate resources. The chat function is on, but will not be monitored for questions during this session. You are welcome to network with one another and to share your personal experiences and comments in the chat. Finally, if you know someone who wanted to join this evening but wasn't able to do so, please tell them that this recording will be live on our website in our video library, and we'll notify the community when it's public. Be sure to subscribe to our newsletter for those notifications at dtrf.org. All right, we still have a couple people rolling in, but let's go ahead and get started. Narcy, let's hear from you first, from your pathologist perspective. For those new to this disease, can you please explain what desmoid tumors are, why they are classified as they are as intermediate locally aggressive tumors, and how this classification helps to determine what happens next in a patient's care?
Thank you, Katie, for the introduction. So, as Katie mentioned, I'm a pathologist, and you can see I'm in my office, and this is my microscope in which I pretty much see slides and make diagnoses. So, whenever desmoid tumors fall under the spectrum of soft tissue tumors, and if we look at the WHO classification of soft tissue tumors, we see that they're classified based on what kind of differentiation they undergo. So either it could be fatty tumors or fibroblastic tumors or skeletal muscle tumors or bone tumors. So desmoid tumors fall under the category of fibroblastic, myofibroblastic tumors of soft tissue. And each category, initially, maybe if you had seen 10, 20 years ago, we would have either a benign category or a malignant category. But then as we know more about these tumors and their behaviors, we introduced a third category called locally aggressive category, where we know that tumors, so benign tumors are, once you remove them, you can forget about it. Patients, you don't have to follow up. And malignant tumors are tumors which can metastasize or go to different places in the body. And those tumors really need a special line of therapy. Those locally aggressive tumors are tumors which are, we wanted to remove them out of the benign category because we know that they can be recurrent. In other words, once you get them out, they may come back. Or they may have a very infiltrative pattern of growth, which makes it difficult for the surgeon to remove or know where exactly to get the borders out. So these are tumors which sort of now are put in this intermediate category of locally aggressive, non-metastasizing tumors. So these cannot spread to different parts of the body, so they don't have lung metastasis or any other metastasis. But wherever they form in any part of the body, they can have an infiltrative pattern, and even if removed, they can sort of come back. And sometimes they can spread very aggressively. So another term for this is aggressive fibromatosis. So that's the general background of how this tumor is classified. And just generally, the first point of contact for us is a biopsy of the tumor. And when we in pathology get a biopsy of the tumor, we look at it under the microscope, and desmoid tumors have a particular pattern, but sometimes on small biopsies are small little tissues. It's not the entire tumor. So sometimes when the tissue is less, or usually it's the core of tissue, there can be some other tumors or other differentials, and we have to tease out desmoids from the other. For example, you may have a surgery and you may have a simple scar, and you get a core of the scar tissue, and sometimes it looks exactly like a desmoid. So for us, getting a clinical picture of whether there's a mass forming lesion, whether the lesion was adequately sampled by the intervention radiologist or the surgeon, aspects and the clinical history is really important. Plus, we now in the last 10 years have better tools. We have an immunohistochemical stain for beta-catenin, which which we routinely do on anything we think of could be a desmoid, and we are looking for a specific pattern of staining of beta-catenin. And if everything fits, then we make a diagnosis of desmoid type fibromatosis. So maybe about 10, 15 years ago, it was just based on morphology. Now we can be a little more specific by doing immunohistochemical stains. And there is an option to do molecular. We can talk about it later. But as a routine, it is an initial examination of the tissue, and by doing special immunohistochemical stain for beta-catenin, that the tumor is diagnosed.
That's
And once we diagnose it, we issue a report, and it's further acted upon by the rest of the team.
that's so helpful, Narcy. We don't always have that inside look at, what's happening in the background
Right.
to get to our diagnosis. Ashley, coming over to you. You bring such valuable expertise from a mental health perspective for our community. How have you experienced when we hear desmoids classified as benign? How have you experienced that affects desmoid patients and caregivers? And what are some of the emotional and social challenges people face when navigating a rare disease diagnosis like desmoid tumors, especially one that can be so complex to explain and is often misrepresented?
Yeah. Thank you for having this discussion because I think this is such an important question for the desmoid community. At the Desmoid Project, when we lead support groups, we actually dedicate an entire session to this question because we find that the benign classification has some pretty significant psychosocial effects. So while medically we might understand that benign means our tumor is not metastasizing, from a social and psychological perspective, what that infers or how people interpret the word benign is this isn't serious, this isn't dangerous, it's not a big deal. I think someone said it earlier, even you just cut it out and it's over and you can kind of move on. But I think the medical terminology is very, very different than the lived experience of a desmoid tumor patient. And so having the term benign attached to our tumor often leads to kind of a cascading effect of psychosocial effects that a desmoid patient might experience. And so one of the first things that we see is that there tends to be the minimization or the dismissal of the diagnosis. At the Desmoid Project, we actually completed a community needs assessment several years ago in order to get a pulse of what our community was feeling and the things that they were dealing with. And about 50% of those who answered that assessment shared that they felt as though their diagnosis was dismissed or misunderstood. And when a diagnosis is dismissed and misunderstood, often we don't get access to the same resources. So 75% of people who answered that questionnaire said they've never been referred to mental health services. Of the 25% who have, they said the average time was 3.5 years before they were referred to mental health services. So we just don't often have the same access, which then can lead desmoid patients to compare their situation with maybe other diagnoses, especially when we're being seen by oncologists. We might compare ourselves to a malignant cancer. And that comparison can lead us to feeling like we don't really belong anywhere. And the thing that I hear the most, probably in the desmoid community, is I live between categories. And so I don't fit into the cancer category. I don't fit into the healthy, benign category. And so I feel like I don't have anywhere to belong. And that lack of belonging can lead to a whole host of other kind of psychosocial symptoms. So things like anxiety or depression or isolation, maybe even guilt. I shouldn't be experiencing this degree of suffering, or I shouldn't be struggling this much. And I think one of the things that we see the most that deeply affects the patients that we work with is just this difficulty with how do I even answer the question of what is a desmoid tumor whenever people are asking me, my friends are asking me, my family's asking me, because how I answer that question often can either make me feel like you don't understand the gravity and the seriousness of my diagnosis, or am I an imposter by calling it something different than how it's termed medically? And so there's a whole host of psychosocial implications for a desmoid tumor being called benign. And oftentimes it can just lead to feeling dismissed, feeling minimized, feeling alone, feeling like I don't belong anywhere, and then having to deal with the mental health ramifications on my own.
Ashley, thank you so much. You know this, and other people on the call, many people on the call know this, that I have a desmoid tumor diagnosis as well. And every time I hear you speak, I feel seen. And it doesn't change my diagnosis, but it certainly changes my emotions. It helps me feel seen and validated. So I so appreciate you. Mernal, over to you. You work every day with patients navigating their desmoid tumor diagnosis. Some are newly diagnosed, others have had this diagnosis for years. How can you tell us about how the diagnosis leads to treatment decisions? How are you thinking about that as part of a multidisciplinary team? And can you speak a bit about current treatment options for desmoids? Hold on, we got to get you off mute, Mernal. We don't want to miss a word.
Okay, no, thank you. Thank you, Katie. First, I want to say that, I've been doing this now for 15, 17 years. To the best of my knowledge, this is the first time we are tackling this particular topic, right? To have a psychologist, a psychologist as part of this conversation is so important. It's something that I don't think the DTRF has done, or really anyone else has done. So I'm so happy for Ashley to be here and really sort of discussing this issue. Um, I will get to sort of the treatment pyramid decisions, as well as the, how do we make those decisions, as well as the the different options. But to just pick up on what Ashley said, so much of what medicine gets written up and described is how physicians write up the language and the text of what a disease is, whether it's blood, hypertension, diabetes, whatever it is very much as how physicians observe it. Very rarely, and I think only in the last 5 to 6, 7 years, has medicine shifted to saying, well, what is the patient's lived experience? And increasingly, not just how medicine is being treated, but also how regulatory agencies like FDA and others are looking at is the intervention that we are doing, is it really helping patients or not? And I think for me, the biggest lesson here was, 5, 6 years ago, we had a big conversation in the Medical Scientific Advisory Board about whether to develop a patient-reported outcomes instrument or not. And I can tell you that most of the physicians and the scientists were against it. They said, you're not going to learn anything from developing a tool about what patients are going to say. We already know what they're going to say, right? And it was such an eye-opening experience, because when we actually did the research, when we actually got patients through the DTRF to sit down and say, what is it that you're feeling? There were so many things that physicians had completely missed, right? Because you have a 15, 20-minute appointment. You're not really asking about sleep. You're not asking about anxiety, isolation, depression. So much gets completely missed. So I think this tool that has been developed by DTRF and in collaboration has really been eye-opening in this topic. So in some sense, benign is a word used by pathologists, but more and more, I think maybe the right terminology is aggressive fibromatosis, because that speaks to the clinical behavior of what actually happens. So although the word aggressive fibromatosis is being used less and less in literature and in publications, and desmoid is being used more, I think the word aggressive fibromatosis also speaks to the clinical biology. When I see patients at Sloan Kettering, it's usually as part of a disease management team. So I represent, there's 12 other medical oncologists. I'm one of many. Then there's a surgical oncologist, the pathologist, as well as a radiation oncologist. Every new patient who comes in, we all look at the scans, we talk about the patient and the pathology. NARCI and others discuss that this is the pathology. And then the question comes, well, what is the best treatment option here? And I think that is extremely, extremely important, whether you're being seen here or any part of the globe, is to get a disease management team. This is not a one-person show. This is a team-driven effort. So I think for all the people who are hearing this for the first time or have heard it before, the best treatment for desmoid tumor begins with making sure the pathology is correct. So if you don't get that right, you are going to be completely in the wrong direction. And some patients do get the wrong diagnosis until they come to a larger center, then the pathology gets reviewed here. So getting the pathology right by expert sarcoma pathologists such as NARCI is the first and most important step. Then, we look at it as a group, and we also bring the patient perspective in. And one of the key questions I ask the patient is, are you symptomatic from this? How long have you had this? Are there activities that you normally do that you're not doing? Some patients say, I don't feel anything. I think I'm okay. But if you really sort of dig deeper, they'll say, well, I stopped playing tennis. I stopped doing this. I don't go to the gym anymore because I worry that if I go to the gym, I may make it worse, or, the pain then comes up. So if you sort of probe, then these, the true symptoms do come up, right? So you really have to ask those questions to the patient. Be like, how symptomatic are you? How else is this impacting you? And, I had a patient who's not having any pain, but he says, I used to love swimming, but I can't go swimming because I got this big thing on the back of my spine. And I'm really worried about my physical appearance, when I go swimming. So that could be another reason to say, well, should we treat or not treat, right? So for me, how are the patients feeling? What are they saying is the number one thing, more than even what scans or anything else show. The second thing is this tumor growing? Is it in a dangerous location or not? So I think these are all the parameters that we kind of put together. And in collaboration with the patient, you have to say, is this also the right time to treat? And some may say, well, I think I'd like to wait for 3 to 4 months and then maybe watch it, maybe take an active surveillance. Others may choose active surveillance, but I'll have to convince them that it's actually the wrong approach, that for them, treatment is the right thing to do. So it's a lot of iterative process. It goes back and forth. And this all gets part of this tumor board or a disease management team tumor board. And ultimately, the decision comes to, should we treat or not treat? Is it safe to watch, not watch? When we make the decision that it needs to be treated, there's a whole host of options right now. The way I think about it generally is there some kind of a local therapy, such as a cryoablation or a radiofrequency ablation or a HIFU or transarterial chemembolization that could solve the problem in a hyperlocal way? And you have to be, and I won't get into it right now, but if that's not the best option, then you have to ask the question, what is the best sort of a systemic treatment? So I know in general, we've been avoiding surgery for many years now, and we've absolutely not given radiation to any patient in the 17 years that I've been practicing. We've avoided radiation because we've just seen some bad outcomes. So typically systemic therapies are what we discuss. And, right now we have this FDA-approved drug from SpringWorks, nirogacestat or Ogsiveo. There are other standard of care drugs such as sorafenib, chemotherapies, and people hear the word chemotherapy and immediately kind of, panic. but many of the drugs, chemotherapies that we use can be gentle. The big takeaway I would say is from a physician perspective, before I walk into a room to meet a patient with desmoid tumors, I always remind myself and say, curb your enthusiasm, right? Because as a doctor, we want to do something to help a patient, right? We want to do something. Sometimes, like, not doing something is also action. And we have to remember it because patients may say, I just want it out. I just want it out. I want to get back with my life. I just need to do something to get back on track. And it takes a lot of time to convince them that sometimes less is more. And sometimes the treatments that we offer should not be worse than the desmoid tumor itself. So to me, those are like the two biggest lessons is that whatever treatment we offer should not be worse than the disease itself. And two, that you have to take the whole patient into account, not just a scan, not just like fear or anxiety that sometimes drives the decision making process.
That's so helpful. Thank you so much for framing that, Mernal. And it's always so important, I think, for patients and caregivers to hear about the team element, the team aspect of what you're doing, and that you are truly looking at the whole patient. I love this. I love when you say like someone using the example of someone who loves to swim and said, I haven't gone swimming, even if it's just because of cosmetic, but oftentimes that's because of pain or mobility. Okay, well, let's get you back in the water. How are we going to do that? So I really appreciate that. Narcy, Mernal had mentioned the importance of making sure the pathology is correct. We had a handful of questions about the role of genetic sequencing in desmoid tumors. Can you speak to that for us so we can better understand the importance of genetic sequencing with our disease?
Sure. So, with the advent of better sequencing techniques and next generation sequencing, in the last 10 years, pretty much in every tumor, we've come to know the genetics better of each tumor. And for desmoid tumors, from studies from here and from other places, we know that they have a mutation. About 85 to 90% of desmoids have a mutation in the beta-catenin gene. And it affects a particular pathway. There are some very specific mutations that are involved with the beta-catenin. And the rest, for 5% or so, have a mutation in the APC gene, which can cause polyps in the intestine and other related symptoms. So, especially on biopsies, when we have small amounts of tissue, and let's say our stain for beta-catenin is, we are not comfortable calling it, but we are clinically suspicious of fibromatosis, we can resort to doing sequencing. And it is not like we need it in every case. I would say maybe about 10% or 10 to 15% maybe we may have difficulty in making a definitive diagnosis. And in such cases, we recommend doing sequencing. And if it is in MSK, we have our own sequencing in a molecular study. If it is outside, now pretty much every institution everywhere is associated or they send it out for sequencing. And I've seen reports from outside as well, where they have sent it to sequencing and identified the beta-catenin mutation. So it is more based on the pathologist's comfort level. And sometimes not all biopsies are alike. Sometimes biopsies are, we get good tissue. Sometimes the tissue is a little bit less. So it just depends on the comfort level in making a diagnosis. And what we don't want is to miss making a diagnosis of fibromatosis. Or we don't want to call something else, which is more benign, like a scar of fibromatosis. So especially when we are ambivalent with the diagnosis, then we resort to molecular testing, which can be confirmatory in making a diagnosis of fibromatosis.
That's really helpful. Thank you, Narcy. Mernal, talking about the diagnosis, a lot of the patients are really interested in current research and what is happening with clinical trials and other research that may be informing um, treatment plans. Can you speak to that?
Yeah, so 10 years ago when we were doing this together, we had one clinical trial, and we did not think we'd have a second sort of a big clinical trial, but we I think the DTRF has really created a critical mass that's now allowing drug companies to say that, well, this is an important population. This is something that we can feasibly do this. So I would say that, currently we have many clinical trials that are ongoing. Some of the clinical trials are early phase. We call this phase one or phase two clinical trials, where the drugs are still being tested, not just what is the right dose, but how often you should do it. So one of the clinical trials is looking at this beta-catenin mutation that Narcy just mentioned. And this is an inhibitor that goes right after that primary driver mutation that we see in desmoid tumors. There are other clinical trials such as the gamma secretase inhibitor, so nirogacestat. Varegacestat just completed a very large phase 3 clinical trial. Those are also targeting some of those same mutations, but maybe further downstream of what's happening in that mutated pathway. So those are some of the clinical trials that are going on both in the US as well as internationally. And I believe there are some clinical trials also looking at cryoablation.
Right.
So I think DTRF has funded a trial looking at a global cryoablation protocol as well. Is that
That's
what you wanted? Do you want to know more?
Yeah,
Or
I think
more
so.
specific?
And, we could, any one of those that you just brought in, we could have an entire webinar or entire weekend talking about. And we do everything that you just mentioned, we are planning to talk more about this year. So I really appreciate you framing that. There's so much technicality behind this, and we have to learn as we get diagnosed and our diagnosis progresses over years. There's so many new vocabulary words and concepts we need to learn. So I want to bring this back to you, Ashley. So many of us in the community struggle with the uncertainty of living with a tumor that can persist long term and that is complicated to understand and that has treatment plans that may change year over year or not. How can participants cope with this uncertainty and the emotional impact of it all? How do you support patients in managing the psychological challenges of chronic disease and this long-term monitoring that we have as desmoid patients?
It's a great question. I think the first thing I would say is when dealing with something chronic and uncertain, we have to make a psychological shift really from, okay, when this is over, then I'll get back to living my life, to, okay, I can build a meaningful and beautiful life alongside dealing with something that is uncertain. And so that psychological shift is really the beginning of the process of really being able to cope. It's not necessarily always about being strong or being positive or having the grit to get through it. And while those things are very good and positive, the reality is accepting the uncertainty can be a very hard process, but a very necessary process. And I think at the Desmoid Project, some of the things that we really focus on to be able to help people cope with this diagnosis is one, providing a space for people to be able to grieve and to feel all of the emotions associated. Grief is about loss, and there's a lot of loss in this process. And so being able to grieve and know that in this space, that's not going to be minimized, that's not going to be dismissed, the recognition that grief exists. And then on top of that, really being able to find a community of people who understand. We are very adamant about support groups and strength in the community of desmoid patients and really coming together because just like we mentioned before, there is such difficulty in explaining our diagnosis to people who don't necessarily understand it, that when we can come together as desmoid patients, we're cutting out a whole area of misrepresentation potentially. We don't have to explain our experience to other desmoid patients. So I would say grieving, being able to feel our emotions, coming together as a community, and we also really focus on making meaning out of what we go through. And making meaning doesn't always have to be being thankful for or being okay with, but that acceptance and understanding that there is a lot of uncertainty in this process. And alongside that uncertainty, I can make and create a life that's meaningful and beautiful at the same time. So.
That's really helpful. Thank you, Ashley. Mrinal, coming back to you, we know that kind of like Ashley was talking about, we have to explain our disease so often to many people, and that in and of itself is burdensome, right? We know that many desmoid patients aren't as lucky or as fortunate to be near a sarcoma center of excellence. And even if they are being treated at a sarcoma center of excellence, they might only visit once a year. And so they are often the ones that need to explain the classification of desmoid tumors as intermediate, locally aggressive, not benign to their local care teams. Can you speak a little bit about practical steps that patients can take to help educate their healthcare providers about current desmoid tumor classification and standards of care? Like, how would you coach a patient or caregiver to talk about this disease in a way that is validating and helps them get the resources they need and the treatment plans that they need?
Sure, yeah. No, I think that's a very important question. And I think obviously it's very challenging to explain all of this, right? Like from pathology all the way to the treatment to an oncologist who perhaps has never seen something like this in the local community. But I do think that there are some good resources. I think on your own website, there is an excellent page on what is a desmoid tumor, right? And it's a 1 page, 2 page thing. I think that's something that that certainly that link can be shared with with your local oncologist, with your surgeons, with your nursing team, so that they can also be familiarized with themselves. I think it's a very high burden to put the patient to say, now you need to explain to somebody else what this is. And people come with varying degrees of health literacy. So to put that burden on them to also explain something that, even among sarcoma experts, we all debate about, you know, we don't have a consistent consensus on everything as well. So now to tell the patient to now you also need to communicate, I think it's a little too much. But I think the educational seminars such as this, or like the videos that you have created and on your website, I think it's an excellent resource, not just for local oncologists, but also like maybe if you're in an emergency room, right? And there's somebody who's standing there who's like, I've never heard of something like that. Let me Google it, right? But instead to say, well, here's a link that is consistent. So I've actually pointed to your website on numerous occasions to my patients who sometimes come see me once a year or twice a year, not just for them to educate, but also as a way to communicate with other caregivers in their local community.
Thanks so much, Mrinal. And I know you like to talk to your patients about what they can be doing to support their health in addition to the medical treatments and interventions. What else do you, encourage or talk to your patients about from that perspective?
Yeah, I want to pick up what Ashley said, and I think only recently have I myself have been more proactive about referring my patients to seek therapy to discuss the sort of the psychological trauma of being diagnosed with something like this and the uncertainty. We as oncologists, and I'll speak for myself, are much more prone to make those referrals early on when there's a malignant condition that is, say, metastatic, right? When we see a desmoid patient, I think I'm guilty of not referring them to therapists very early on. And I think patients also may are not asking that question. So I think if there's one thing that comes out of this webinar, it is that I think patients should ask their physicians for referral, or they should seek it out on their own to sort of have this conversation about mental health. I think this is not one. The desmoid tumor is not a 100-meter sprint, right? Sometimes this can be a marathon, and having good mental health through this process is extremely important for the overall well-being of that person. So having said that, the other thing that I do talk to patients often is about physical therapy, because usually some of the extremities and other things are involved. Sometimes people end up protecting a certain extremity, which can actually do you more harm. So I say, getting physical therapy is extremely important. Um, you know, in that context, I'll say, you should maybe look into yoga or other practices. But exercise overall, as you know, also helps with your mental health. So I really encourage people to do those things. And so that's one of the things that I do. People do often ask about, is there anything I should change, modify in my diet, and things. So to the best of my knowledge, I'm not aware of any dietary modifications that change the equation for desmoid tumors.
Thanks, that's really helpful. Narcy, we had a really interesting question. Feel free to pass this if you need to. It was that, well, I think this goes along with the mental health question too, that we go to oncology centers and we go to sarcoma centers of excellence to be treated, and that comes with its own weight. And so, Ashley, I want to come back to you on that as well. But Narcy, from a pathology perspective, we know that desmoid tumors are often treated by physicians who treat sarcomas, by sarcoma specialists. Can you just speak to what characteristics do sarcomas and desmoid tumors share that might help patients and caregivers be able to explain why they're being treated by a sarcoma specialist or why they're going to a sarcoma center?
Sure. So just in medicine, or the way medicine is practiced, we can broadly classify tumors based on where they occur. So if it occurs in particular organs of the body, like lung, breast, where the lining cells have a particular function, we call them carcinomas. But then when tumors occur in the support structures of the body, like bones, some fat, everything is a support structure: bone, cartilage, supports fat, muscle. Then we call them sarcomas, or spindle cells, soft tissue tumors. They have a different origin. They're mesenchymal origin rather than epithelial origin. So anything in the support structure. And these desmoid tumors occur mainly in the arise from the support structures. And this is more of a fibrous component of tumor. So that is where it shares similarity with other soft tissue sarcomas in its mesenchymal origin of tumor. But again, each tumor, there are about 50 different tumors in the sarcoma category, which is why, but morphologically under the microscope, some of them can look very similar, which is why we have to utilize additional immunohistochemical stains to be specific as to what kind of tumor it is and try to classify it well. So just also adding on what Mrinal was saying, most people are being seen out of in the community. I guess most community pathologists are aware of the tumor, and nowadays the immunohistochemical stain is rather widespread, so most labs have it. It's just that since this is an international forum, I mean, I can say that sometimes, depending on the country, you may have a deficit in how pathology is practiced or the diagnosis is made. So I would say, getting a pathology referral from any sarcoma center may not be a bad idea if you're not part of the. And the adjunct benefit of getting a pathology referral would be that, again, it we would discuss it as part of a disease management team. So even if you're treated locally, just getting one referral and making sure, they would do the same thing at a sarcoma referral center sort of goes a long way in reassuring you that your disease is well managed or your diagnosis is right.
Thank you so much, Narcy. I really appreciate that. And you mentioned the international community. I just want to take a moment to say that DTRF does host a tumor board, an international tumor board, once a quarter. So the next one is coming up in May. And so if you are a patient or a caregiver who does not have the privilege or the opportunity to have your case looked at by a multidisciplinary team, you can have your clinician submit your case to our tumor board on our website. Just look for Submit Your Case. And that is an opportunity for your case to be brought forward and discussed by a multidisciplinary team. We often have over 24 people on those tumor boards, and it is led by our medical advisory board at Desmoid Tumor Research Foundation. So we really encourage folks to take advantage of that opportunity. Ashley, Narcy was talking about referrals. And I know that how desmoid tumors are classified, picking up on something that Mernal mentioned as well, can affect patients emotionally and in their treatment plans, and also to referrals to specialists. What guidance do you have for, encouraging or supporting desmoid tumor patients and caregivers and accessing support for mental health, for pain management, for fertility counseling, etc.? In other words, how do you guide desmoid tumor patients and caregivers to advocate for themselves, especially when they may feel that their disease has been minimized or even dismissed, as you mentioned earlier?
My biggest encouragement would be to be proactive. I think when our diagnosis is minimized by others in our life, whether it's medical professionals, family, friends, community, we have a tendency to internalize that minimization and minimize ourselves. And so the question becomes, does my diagnosis really warrant this type of service? Mental health, fertility, information or education. And I think my biggest encouragement would be proactive. This diagnosis is deserving of accessing the resources that are available to you. And I think with something like a desmoid diagnosis and the chronic uncertainty associated with it, to have mental health support throughout the process and to have community throughout the process is a huge buffer to being able to deal with the diagnosis long term. And so one of those referrals obviously is the Desmoid Project and the programs that we provide with being able to provide support groups for desmoid patients. But also we have something called the Gathering Tree, which is drop-in sessions to just be able to connect with patients and other patients that might relate on a specific topic, like moms or men, or more specific catered topics to select populations within the desmoid community where we can connect and kind of walk this process together.
And I want to mention too that one of those groups has been folks who have the FAP gene as well.
Yes.
And so I just want to highlight that, and so we've mentioned a couple times the importance of community. And when we have a rare disease, it's so hard to feel like we're actually part of a community. But here people are hearing there are 2 organizations here for you. And we often start when we get an email about someone who's newly diagnosed and they're presenting their case to us, we try to start with, you're not alone. And here you have DTRF as a organization that has resources for you, educational resources, and has we're doing research on the disease to help create better treatment options for you and ultimately a cure. And we have the Desmoid Project that is a whole other entity that is here to support you specifically in your mental health journey. So there are communities for us. This question is one that came from one of our registrants to this webinar who came just, I believe, yesterday, registered. And they asked, in what ways, so this is a question for any of you to answer or all of you to answer, in what ways, big or small, could a loved one support one diagnosed with a desmoid tumor? Is there anything that you have all seen in working with desmoid patients that has helped made things even a little easier for the desmoid patient, the desmoid warrior?
I'm happy to share because I think there are big and small ways that someone can be supportive. But I really do think it's in the small ways that are consistent over time that can really make the biggest impact.
Right.
I find that often if someone doesn't understand what I'm going through, they'll ignore it because they don't know how to engage with it or address it. And I think even just the acknowledgement, reaching out, remembering an appointment, asking where I'm at in the process, that is huge because I've heard so many times, and I understand it myself, that sentiment of, well, I don't want to bring it up because I don't want to remind you of it. And I can guarantee you, you're not going to remind me of it. I think about it all the time. And so you don't have to worry about that, but just the recognition that this is something hard and especially recognition after the treatment phase. A lot of people tend to be supportive during the treatment phase, which is wonderful and beautiful. But afterwards, that tends to be the time when all the emotional processing starts happening for the patient. And so just to show up and say something is beautiful. And then I would also say practical support, not necessarily asking, hey, let me know what I can do for you, because most of the time we might not reach out. A lot of times we feel like our diagnosis is a burden and we don't want to burden someone further. And so being able to offer practical support is huge. I remember even my personal story, my parents know how much I love my dog. And so I live in a 3-story townhouse. My room is on the top floor, and I had legs that weren't working while I was going through my treatment. And so they would come over, they'd take my dog out for me so that he could stay with me. So recognizing those areas of practical support and being able to step in without necessarily asking the patient to be the one to reach out for it, I think that's huge as well.
That's such an important message and reminder for us all. Mernal, anything you would add?
I agree with everything that Ashley said, but I also think to remember to be patient. You know,
Mhm.
you have to be really patient. Um, there are starts and stops, and just when you think that you're kind of done 9 months into it, it may recur again.
Mhm.
It can be really difficult, and there could be a lot of caretaker burnout. So
Right.
while caretakers are trying to do their best taking care of the patients, I would say if you want to be a really good caretaker, you have to take care of yourself as well. And I think again and again, coming back to this concept of being patient is extremely important. There's ups and downs with this disease that happens. There could be long periods when things are fine, and suddenly things may just come up again.
Yeah.
So just being empathetic and compassionate during that process is supremely helpful.
Thank you so much, Mernal. This has been an extraordinary conversation, and I want to thank the Desmoid community, so the folks who registered for this webinar, as well as our DTRF ambassadors, who are a group of folks who come together monthly to discuss the work of the foundation and to help guide some of these educational experiences like this webinar. Thank you so much for your valuable questions, and I'm so grateful, Ashley, Narcy, and Mernal, for sharing your expertise. Um, I'm tasked with providing a couple of my own takeaways, and I have so many, but 3 that I'll mention right now are that coming together as a community, and especially in a rare disease space like ours, can be so validating emotionally and for our mental health. And it also can spur action and answers. So please keep showing up. Please keep being proactive with your care teams and find ways to be engaged in the Desmoid community to the extent that you're able to do so. We know that's not possible for everybody at every time, depending on what stage you are in your disease, but we encourage you to be here to show up when and as you can. I also really want to highlight what I heard from Ashley when she said that the psychological shift, that this is a disease that is chronic, it is long-term. Going back to what Mernal just said, it can change. This is the beginning, that psychological shift and accepting that is the beginning of the process of coping. And so in whatever way we are able to do that, hopefully by following some of the guidance we heard here today can help. And finally, there's so many complexities to our rare disease. There were so many questions that we didn't get to about the biology of our disease, about the research, about new treatments on the horizon. And we want to encourage you to keep learning, to engage with the resources that DTRF is providing, to engage with Desmoid Project and their messages and their communications, because they every day are bringing new important information to the field around the mental health and the psychological elements of our disease, and to keep showing up for yourself. The more you can do that, the more you keep learning, the more as a community we will be able to move towards a cure for each and every desmoid patient. I want to remind once again that these webinars are made possible via sponsors like SpringWorks Therapeutics, who is our sponsor for this webinar, and also by the generosity of this community, which is extraordinary. If you'd like to make a gift to support more educational programming as well as our research grant funding program, please visit dtrf.org. And please know that every contribution, no matter the size, matters, and it makes a difference for us. Remember to register for our upcoming events. We have an in-person event, Living with Desmoids, a DTRF educational experience, coming up in Columbus, Ohio on April 25th. And that is where we have a multidisciplinary team speaking about how they make treatment decisions and what is currently happening right now in our field. And please save the date for our annual Together We Will weekend in Philadelphia, PA, on September 25th and 26th. You can find more information about these and other events on our website, dtrf.org. Just a reminder as well to sign up for our newsletter. It comes every other week and is a really great resource for learning and for staying abreast on the events that we have. Once again, before we close out, I want to extend a huge gratitude to our panelists, Ashley Williams, Mernal Gounder, and Narsi Agaram, for being with us today. Thank you for your absolutely incredible dedication to the desmoid community. Please keep going. Our vision at DTRF is to find a cure for each and every desmoid patient, and it's clinicians like the three of you that are moving us closer to that every day. Finally, and mostly, would like to say a huge thank you to the community for being with us today and for being attentive to our Spread the Word campaign. We invite you to keep spreading the word throughout 2026. Continue sharing accurate resources, continue engaging with our content, and helping us raise awareness wherever conversations about desmoid tumors happen. A reminder that the recording of this of this webinar will be available shortly and will be posted on our video library. Thank you all for being a part of DTRF, for being a part of the desmoid community, and wishing you all a peaceful evening. Take care.
Thank you.
Thanks, Myrna.
Thank you so much.
Thank you, Narsi.
Bye.
Thanks, Ashley.
Bye, everybody.